Okay, well, hello, folks. Good afternoon or good evening, everyone. Thank you for joining us for another session of Virtual Global Spine Conference. We are excited to have everyone join us here again on our weekly live sessions. And I am accompanied here by some of our co-hosts and panelists, Drs. Galgano, Selby, as well as Dr. Mamagani. And I'd like to welcome everyone. We are excited today about a special guest, a friend, a fellow spine surgeon and a colleague, Dr. Mohammed Abd-El-Barr, who is an associate professor of neurosurgery at Duke University. He's also heavily involved in the training of residents and fellowship, as he is the co-director of the spine fellowship there. Really, Mohammed doesn't need that much of an introduction. He's in the last few years, he has just absolutely catapulted to be one of the pioneers of minimally invasive surgery, awake surgery, certainly even endoscopy. So and robotics as well. So you name it, he's on top of it. He's way ahead of the curve, and we are really grateful that he has made the time to join us today. So, Mohammed, thank you so much. It's great to have you here, and we look forward to learning from you today. Welcome to the team.
Thank you so much, Ali, and it's a real honor to be here. Most of the people that are on the panelists are very good friends of mine and people that I've looked up to. I want to congratulate actually the co-hosts of this Global Spine Conference, because I think it's really brought people from all over neurosurgery, orthopedics, from all over the world together to talk about things that we're passionate about. So congratulations for that. So today I was going to talk about enabling technologies in the OR. These are my disclosures. Just some disclaimer, I will discuss for those people in America some off-label use of medical devices. And really, this talk was very hard for me because most people know me as a data guy, and I've tried to not put any p-values or anything like that, but just show some cases and discuss about how I use enabling technologies in the operating room. So when we talk about enabling technologies, we really want to say that these enabling technologies should allow us to do safer surgeries, more efficient surgeries, and if possible, unique surgeries. And those are things that we're going to look at each kind of technology as we bring them in and say, do they really make our surgery safer? Do they make it more efficient? And do they allow us to do surgery in ways that we weren't able to do previously? Just as a word of caution, I'm going to show a lot of, really success stories and so on, but there are failures. And that's something that we probably at another talk could talk about is, what are the limitations? I'm not going to spend too much time this talk talking about limitations, but we really need to realize that not everything that glitters is gold. As I tell my trainees, there is no substitute for sound anatomical knowledge. So if your robot breaks down, if the navigation breaks down, you should still be able to finish that case. And if you're not able to finish that case, then that's a problem. And so I really tell my residents and fellows that, you have to know exactly where you are and what you're doing. Another thing that, I take to at heart is that I never trust the technology completely. And, I think it's an adage that a picture of fluoro never lies. So if you're ever worried, I always take, spot x-rays to make sure that what I'm doing makes sense. I continuously look at the strengths and weaknesses of each technology, and you have to realize there is a learning curve to everything that we bring into the operating room. So I trained as an electrical engineer long time ago. And so there's Moore's law that says that technology advances so quickly that, and we see this all the time in our lives, that the rate of advancement is more than exponential. And so sometimes it gets dizzying, what technology should we use in our operating room, which technology should we not use? And so that's something that, we have to be very careful about. I think that whenever you're talking about technology adoption, there's this chasm where you don't know whether that new technology that you decide to trial or not is going to really make it over this chasm. And this is where the early adopters are. In parallel to this, there's also something called the new technology hype cycle, where there's a lot of new technology, there's a lot of hype. Everybody's, oh, you need to buy this, you need to buy that, you need to do this, you need to do this. And then maybe some things don't work so well, and you start having some failures and so on. And I think that there's a real, parallel between where you are here and where this chasm is. And I really think that how low this disillusionment really makes a difference about whether the technology will be widely adopted. So with that, we're going to start off with some cases and show, how I've kind of put some enabling technologies into play in the operating room. So this is a 76-year-old lady, with the normal past medical history that we have. Just to give you a little also background on her, she came to me after she had done a lot of conservative management, and it was it was before the pandemic, and I scheduled her for surgery, and then the pandemic hit, and she was canceled, and then we brought her back, and we were going to do surgery on her again, and then we'll talk about exactly what happened. So this is her. You can see here from her imaging, she's got a spondylolisthesis of L4, L5. She's got a small spondylolisthesis of L5S1. She doesn't have a lot of central stenosis, mostly foraminal stenosis, and she's 76. You can see here from her dynamic imaging, that spondy becomes even a grade 2 at L4, L5. You can see her parameters here. For a 76-year-old, her parameters actually are not that bad. And just to fast forward, I had her scheduled the second time for surgery, and I got a call by the head of the operating room the night before saying, we're going to have to cancel her case because we have another variant of COVID. And so I told the head of the operating room that I can guarantee that this lady will leave the same day of surgery. So that I put a lot of pressure on myself. And so we'll talk about what we did. So, I said, well, if, this is a 76-year-old lady, I know you guys have a lot of discussions about how you do the surgery and which different corridors you use and so on. But I felt with a 76-year-old lady, a 2-level TLIF would be helpful to help her. So what we've done is we've kind of broken down this surgery into discernible steps. So placing pedicle screws, interbody, and I put plus or minus decompression. So we really, if you're going to be a real minimally invasive surgeon, it's not really the incision that makes the most sense, but what you're doing to the overlying tissues that is the most important part of the procedure. So looking at pedicle screws, there's a lot of ways to do it. The ways that we've done now is we're actually using this real-time fluoroscopy instrument navigation. So what happens is that you put the fiducials actually on the C-arm. So there's no real fiducials on the patient. And then just like every other navigation system, you have an infrared marker. And the cool thing about this system is that it allows you to, in real time, measure where you are both in AP and lateral at the same time. So here's a case. You can see 2 pedicle screws going in at the same time. We can see, how far they're going to go. And I can, teach my residents, to do it. And even though it's hard for me not to say p-values, we do have a publication showing that when we looked at placing these pedicle screws, we could cut down the amount of radiation by 70%. We could cut down the time by 67%. And now that we're doing 2 screws at a time, it really makes us be more efficient. And we also have evidence that it is actually as safe as actually a robotic system. So that's how we place in the screws. For the interbody fusion, there's a lot of different ways to do it. But we've really been interested in pursuing Cambin's triangle, or more accurately, Cambin's prism. And so, these are the borders that we all know about, the exiting nerve root. This is a cadaver where they've taken off this, the SAP, but those are the borders that you have. Now, Dr. Mike Wang in Miami has really done a good job talking more and more about Cambin's triangle. So this is kind of how we make our incisions. We have 2 small incisions for the screws, and then 1 lateral where we're going into Camden's triangle. Now, when I first started, what we were doing is actually having 2 C-arms, and having AP and lateral each time. And then with this instrument tracking, we were able to do away with all of that. So there was no setup time, and we could put in these, get into Camden's triangle much safer and much easier. So here's an example. This is a grade 2 spondy. You can see here, this is bone on bone, right? This is a very difficult case. You can also see that that person is a North Carolina resident. He's been shot, so you can't do a ALIF or a lateral. And so this was a very difficult case. So what I had planned was I was going to put in my screws, and then I was going to try to distract and then try to get into Camden's triangle. But then I said, let's try to do it even without distraction. So this is a unedited video. You can see here, the C-arm is in the AP. We take 1 X-ray, we learn our tip there. We take another X-ray in the lateral. And then basically now I'm knowing exactly where I am. I'm using neuromonitoring. I have it set at setting triggered EMGs to 5 milliamps. And you can see I can always take another X-ray to, reboot the system. And now I'm getting into the disc here. I've taken a total of 4 X-rays. And now I'm in. And you can see I'm going to now go a little bit further into the disc. And you can see now the spondy is being corrected. And then I move into the AP just to get my great trajectory there. And you can see here, we were able to do this case. And this case actually was done in 47 minutes skin to skin. So we're able to do fast and efficient surgery on cases that are extremely difficult. So in terms of instrument tracking, I think we're showing that this is allowing us to do safer surgeries, definitely more efficient. We're cutting down radiation, we're cutting our time out, and we're allowing us to do unique surgeries as well. So for those people that are smart, they said, well, you talked about Camden's triangle, but what about the nerves? And actually this came about by a discussion that I had with my chairman here, who's a cranial guy, and he said to me, well, how about if somebody has conjoined nerve roots? So how are you knowing that going into Camden's triangle is safe? And does everybody have a Camden's triangle? And that really got me thinking, can we make this surgery even safer? So what we've done actually is we've taken actually the cranial software, we're mapping out nerves, and we're able to then manually, now we're manually, but hopefully we'll have some better technology where we're able to segment out the individual nerves. And then, in fact, we're able to, with a high resolution MRI, we can actually measure preoperatively the area of Camden's triangle. And so if a person doesn't have a particular side of the radiculopathy, we can of course choose the bigger side of Camden's triangle to go into. So this is what we're doing now. We're segmenting out the nerves, we're fusing the CT and the MRI, and we're making the perfect trajectory into Camden's triangle. We haven't done this in the operating room yet, but it is coming down the line where we're going to use some type of augmented reality to make sure that what we've planned is actually what we're doing. So going back to our 76-year-old lady with the 2-level spondy, this is what we did for her. So, and this is a thing that I think that some of us have overlooked, and something that I've really learned over the last couple of years is that you really have to have a great relationship with your anesthesiologist. So they actually do a erector spinae block with long-acting bupivacaine in the pre-op area. Then they put in a spinal anesthesia, and then we actually have the patients come in with their own earphones to listen to the music that they want. And then we place the pedicle screws using the instrument tracking. It's my practice that, when I put in pedicle screws, I get a CT scan to make sure that the pedicle screws are done safely. So we do that, and then we get the CT scan and we merge it with the MRI. And now I know exactly where the bones are and where the nerves are. And then I can design trajectories into the disc spaces in a very safe way. So here's a video showing that. So here we're avoiding the SAP we're avoiding the exiting nerve root, and we're entering into the disc space. It kind of takes me back to my cranial days. I went into neurosurgery thinking I was going to be a functional guy. So this is, to me, is almost like functional neurosurgery. So this is what we're able to do. We're able to reduce her spondylolisthesis. This is bloodless surgery, right? It's percutaneous. We lose 50 cc's, and thank goodness she was able to go home the same day, because they said if she wasn't going to go home the same day, they would cut off my, ability to operate during the pandemic. And so I think that if you had come to me, even when I finished my fellowship 5 years ago, and said that you're going to do a 2-level TLIF and have the patient go home the same day, I would have thought, that's impossible. But I think we're making that possible. And you think here we didn't do a bad job in terms of her overall alignment. So what are the limits, to awake spine surgery, and bringing in all these enabling technologies. So this was a case that really, I think, pushed the limit. So this is an 87-year-old with mechanical back pain and neurogenic claudication. He tried everything else, and he was at the end of his line. You can see here that his PI-LL mismatch was a little bit high, but remember, he's 87 years old. You can see here he's got a mobile spondy at L4, L5. And more importantly, though, he's got really bad stenosis at L3, 4 and L2, L3. And so this case I really struggled with, because I told the guy, I've only done 1 or 2 level fusions when the patient's awake. No anesthesiologist is going to put an 87-year-old to sleep. So I was really stuck. So I told him, let's reach a compromise. Let me do your spondylolisthesis first, make sure that goes well, and then let's bring you back and we'll do a decompression. And actually I have to give a shout out to my fellow, Dr. Andrew Chan, who's now attending at Columbia. He called me the night before and he said, Dr. Abd-El-Barr, why don't we work simultaneously? You do the TLIF and then I do the decompressions. So what we did was we did an awake tubular L2, L3 bilateral decompression with a 4-5 transfacet TLIF. So you can see here we set up 2 microscopes, and then basically what we're doing is that we operated at the same time. So we were putting in the screws, and then after we put in the screws, I did the TLIF while Dr. Chan was doing the decompression. Again, we used the instrument tracking to put in the screws. This allows us to do it, pretty quickly and pretty efficiently. You can see here we're working side by side. Here's a really cool video. So this is Dr. Chen doing a bilateral decompression. You can see the whole theca from both sides, and I'm putting in my TLIF cage at the same time. This is all when the patient's awake and listening to his jazz music. And this is using the transfacet method. We didn't use a Camden's method in this way because his facets were overgrown, and I felt it was safer to do a transfacet, as Dr. Zachary at WashU has kind of explained. You can see here, we got a good reduction of spondylolisthesis. We did a pretty good job in terms of his parameters. Just small incisions. Operative time was just a little bit more than 2 hours, almost no blood loss. He went home the next day. So we're taking an 87-year-old who previously, was told that he could never have surgery, and we're doing surgery for him, and he's doing really well. 3 months later, he texted me a picture of him riding his motorcycle. I think this is why we all went to spine, is to get people to do the things that they really enjoy. So Dr. Ali said that, I do a little bit of robotics. So we'll talk a little bit about robotics as well. So this is a 64-year-old with back and leg pain. You guys usually do the chat?
Yeah, Mohammed, we do, and thanks for showing those couple of really good cases. So Dr. Selby has a question that from the cases that you showed, do you think that's the most ideal corridor for expandable cages? That show.
Yeah, so I think
a preference of, say, static versus expandable using that trajectory.
So if I'm doing a Kanban's approach, I think that that's a really good place to put in an expandable cage, because you're limited by the exiting nerve root and the SAP, and so you really can't go in big. So you really want to have something that allows you to go in small and then expand. Another thing that we've actually done, for that first example where it was bone on bone, we've actually made a special inserter that allows us to, really save the end plates. So in this case here, if I had done this traditionally, I don't know that I would have been able to really, keep those end plates. So we have a special inserter that kind of works as a retractable roof that allows us to do that more safely. Any other questions?
Thank you.
Okay, we'll move on. So similar situation, this guy, for the trainees, dynamic imaging is really important, because if you look here, it doesn't look too bad, but you can see that he's got some gas in the 5-1 disc space. And then when you stand him up, you can see that he's got a grade 2 spondy. So this guy, he refused general anesthesia. And so what we did actually is we used the robot, not only to put in the screws, but then to make a trajectory into Kanban's triangle. And so we did the same thing. We did a spinal anesthesia, and then, we did the surgery, and it was very successful. This was the blood loss. The rep took a picture of this, and this guy went home the next day. And now we have a whole case series of using the robot to enter into Kanban's triangle and allows us to do these surgeries, bloodlessly, and also if the patient is willing and a good candidate for them to be awake during it. So another application that we found for the robot is helping you really precisely put in your screws, especially when you're doing spinal pelvic fixation. So this was a 48-year-old with invasive colorectal carcinoma. You can see here, he's got huge amount of tumor in his sacrum. This was thought to be inoperable. He had horrible pain from sacral insufficiency fractures. And he really didn't have much time to live. And so what we did for him is we used the robot actually to plan out the screws. And the most critical thing, and I don't think that most humans can do this, is that underneath the skin, we planned it so that the tulip heads can line up. And so this allows us then to pass the rod without using any type of side-to-side connector. And we can do this almost percutaneously. This one, we did kind of a Wiltse for the screws, but now we're actually doing it completely percutaneously. We're doing it for both trauma and tumor. And you can see here the teardrop views. We're able to do a completely percutaneous spinal pelvic fixation with almost no blood loss. He ended up, dying within 6 months, but, he, at the time that he had alive, he was very happy, and that horrible pain was gone. Another thing that we've used the robot for is to use the robot for lateral screws. So here's another case of a guy with horrible back pain. You can see here he's got degenerative disc disease and loss of lumbar lordosis at 3 levels. And so there's a lot of ways to do this surgery. The way that we did it for this guy is we did a lateral ALIF at 5-1 with a 2-level lateral. And then we put in the screws with the patient in the lateral position. So, one of the things that we talked about is efficiency. So I think that, there's more and more evidence that the robot is safe, but I do think that in the current iteration of the robot, it's not that efficient. And that's just the bottom line. Right now it's only one effector, and you can see, we're putting in, when I'm doing the screws, 2 screws at one time. So we really have, I think the robotic companies really have to work on increasing the efficiency. I think it's really important whenever you're talking about navigation. This is a picture I got off the internet. not my case, of frame shift errors. And that's something that's inherently, a problem with navigation. So if you put a fiducial on and something happens where what you think is where it is, you will have a frame shift errors, and you have to be very careful about that. And that's something that I always take spot x-rays before I put my instrumentation in if I'm using the robot.
Mohammed, can I interrupt real quick? Just a couple of questions.
Absolutely.
And if you can go back to that last slide for a second. First question from Dr. Hassan Sharhan, our beloved friend and biomedical engineer. Question regarding learning curve. How many the previous cases? How many cases would you say it took you to be proficient in it and feel comfortable with an efficient manner?
For like a percutaneous TLIF?
Yeah.
So the percutaneous TLIF is something I learned during fellowship. I trained under Dr. John Chi and Dr. Yi Lu at the Brigham. And Yi Lu had done a fellowship with Mike Wang. So I do think that, this takes extra training. I think with the instrument tracking, where I can see where the trainee is in both AP and lateral, I think that it's much easier now for me to teach that technique because I know exactly where they are in both AP and lateral. And so I would say that, for the terms of the learning curve, it's not easy. It's something that you have to kind of work on. I was lucky enough to train with people that were really good.
Okay, got it. And the second question regarding from Dr. Baisa regarding the, obviously, I'm sure you've heard this before. I'm sure you've heard this comment every time you present on these techniques, which is documentation of the fusion rate, the arthrodesis. Are you getting fusions? How are you assessing that? What are how are you going ahead and proceeding with ensuring that there's a good enough real estate for the fusion to occur?
That's a really good question. I think that, and we're studying that right now. It depends on how you want to measure fusion. So if you want to get a CT scan, you'll be surprised about, how poor fusion really is. But if you're looking at, people that have symptomatic pseudoarthrosis, I can tell you that the rate is very, very low, probably around 2 or 3%. And the corridor is big enough. You can put, if it's a high risk patient, sometimes I'll put BMP anteriorly of the cage. But I can say that we're looking at that more and more carefully with CTs, and we have a study that's coming out that should show that. Kind of my experience that the rate of pseudoarthrosis in these cases is actually quite low.
Yeah, I would agree with that. I mean, we're not all getting CTs post TLIFs or ALIFs, and we're certainly, the patients are doing well, like you said, with probably a low rate of symptomatic pseudos for sure. My final comment was just on this picture, which I saw on the internet as well, like you did. And the issue I had, where there's a certain etiquette online for a lot of us who do write social media, and there's certain kind of etiquette, I think. But what I was going to say, which I didn't, but I will say here in this forum, is yes, like you said, there are certain types of errors in the frames and the technology. You have to almost double check sometimes the technology that you're using. Like you said, sometimes maybe take a spot X-ray. But what bothered me about this picture is, unless the patient is very, very, very big, and even then you can kind of tell, this is where any surgeon's understanding of the anatomy is very important, and the technique. And that's why it's important to do a lot of these, in my opinion, open freehand before you get your hands on robots and whatnot, because that is a considerable shift. And I think even if you palpate this, and I do this all the time, if I'm using navigation, I'm still palpating with my finger where the midline is under the skin, and I'm imagining how the screws would go in a, say, traditional open freehand manner. So I think that type of needleization, which is fine, but when you're starting so much close to the midline, I think that should have triggered some red flags. And I found it you know, I found it a little bit surprising that all 4 screws went in and somebody had to actually get an X-ray before realizing they were that far off. So that was just my comment on that picture, because I did see that and I was wondering about that.
I think that's a really good point. And actually, I have my trainees, even with this technology like the instrument tracking, I have them, do a Wiltse incision and put their finger, on the TP and facet junction, and put their jamshidi there first, or the screw if I'm going to direct a screw, before they look up at the screen, because I want them to understand that anatomy at all times, right? And so when they look up at the screen and they're not even close, that means I know that they're really not understanding what the anatomy. So I don't, using technology as an enabling technology is good, but if you don't if you don't have basic anatomy knowledge and basic surgical knowledge, it can lead you to bad things. So I actually don't let my trainees look up on the screen until they think, this is where I would put the screw, and then use this technology for fine adjustments. So I think that, there are a lot of work that's being done on trying to kind of fix these frame shift errors, as well as not, use of fiducials, but other types of technology that can help fix this problem of stereotaxy. So in terms of robots, I do think that it does allow us to do safer surgeries. Again, I put an asterisk there. You got to be careful. With the instrument tracking, one of the advantages you can, you take a spot X-ray and it reconfigures itself. With a robot, it may not be the same way. In terms of more efficient surgeries, I'd have to say it's plus or minus. I do think, with the Cambin's triangle entering in with the robot, also with the spinal pelvic percutaneous fixation, it does allow us to do unique surgeries. So I'm going to switch gears a little bit now to talk about endoscopy, if that's okay. Any other questions?
Well, that's a great segue, because we just had a question pop up from Dr. Burchik about using navigation to facilitate endoscopic spine surgery. And I'm guessing that's exactly what you're going to talk about. So
that's next couple
looks out great.
So this was a interesting case. 73-year-old gentleman who underwent a L4 to S1 decompression elsewhere, and still complained about left greater than right leg pain. This guy's a very intelligent guy. He's a person who designs chips for the fighter planes, and so he had a diary of how much of his leg pain he had every day, and he quantified it from 0 to 10, and he had a diary of that. And he came into my office, and this is a very difficult case, because you can see here that the previous surgeon did a reasonable job with the laminectomies, right? And you can see here in the foramen, he was very tight in the foramen, and this case, and he had almost no back pain. And so I couldn't justify, previously, maybe 2 or 3 years ago, I would have thought about doing a fusion, but he really had 0 leg pain. And so I talked to him that maybe this would be a good case for endoscopy. So he got some, diagnostic blocks that helped more at the L5 S1. And so I took him for a awake bilateral L5 S1 decompression. So for this case, we only used local anesthesia. We did do an ESP block for pain relief, but he could feel it. And so when we got in, here we are. So actually, to Dr. Burchik's question, no matter what navigation system you're using, they always tell you that targeting of the Cambin's triangle is the hardest part. And so we've actually used the instrument tracking to do that. So now it's become pretty easy for us to actually get in there with taking very little x-rays. So I would send you to a paper that we published in World Neurosurgery, looking about using this instrument tracking into Cambin's triangle, and we've really cut down that time. So this is a non-edited one. I just put it in yesterday because maybe I was predicting that Dr. Burchik would ask me this question. And you can see here, I've taken 2 X-rays, and now I'm able to, get into Camden's triangle and do the surgery. So the hardest part of endoscopy, usually they tell you, is targeting, and I think we've made the targeting much easier with this technology. And so here we are. I won't bore you with this. So now we're basically doing a foraminoplasty. And remarkably, and I actually couldn't believe this, but on the operating room table, the gentleman told me my left leg feels better. I'm like, "You sure?" He said, "Yes, I'm sure." So I said, "Okay." And then we did the same thing on the right side, and he said the same thing. So I think, this type of, using, the instrument tracking to get into Camden's triangle, to do endoscopy in this case, I think was really, profound. So he had an immediate resolution of his radiculopathies. He's awake. He doesn't actually have a spinal, so this is all under local. So, I don't have to wait for the spinal to wear off. And he's a he's an electrical engineer for fighter pilots, so he has a diary, and he's still happy. He sends me pictures of his diary of his pain level, and now he's able to do the things that he enjoys doing. I think this is a really good application for endoscopy. I think that if I can say, I think it's in the transforaminal ways that endoscopy really shines. I think for the intralaminar ones, I'm not so impressed because, the tubes that they're putting down there are 10 millimeters, and I don't think there's much difference between 10 millimeters and 16 millimeters, which is the normal metrics tube. And so, even though I do some intralaminar endoscopic things, I think it's in the transforaminal one where, we can do this under just local anesthesia. I think that's where it shines the most. Maybe I'll skip ahead. This was, using endoscopy in the cervical spine. You can see here, there's a young lady with a soft disc here. And so we were able to do it.
Mohammed, before we go too far, as far as the lumbar is concerned, Dr. Selby was asking, how do you deal with at L5S1 with the narrow pelvis, say in males, for example, using the transforaminal endoscopic technique?
Yeah, so there's some tricks that I do. Most of the times I'll start my incision a little bit more medial, and I'll start it more superior. Oftentimes my entrance into 5-1 incision is actually the same incision that I use for L4, L5. I know there's a lot of literature in the pain physician literature saying that, Camden's triangle is almost impossible to reach at 5-1, but I haven't found that the case at all. And I've had very good success with it. I start more medial, and then I'll kind of medialize my hand as I enter into Camden's triangle. But it is something that you should be aware of. I always, if I'm doing a 5-1, I always have the other side prepped as well, just in case, I can't get in one side. I've been doing this now for more than 5 years. I've only had to switch sides one time. So this patient, went home the next day, and her left arm is doing better, and now she's complaining of back pain, as some of our patients do. So I think for endoscopies, I think it does allow us to do safer surgeries. I think with the transforaminal, especially, I think that those are really efficient surgeries. And these are unique surgeries, for that gentleman with the bilateral radiculopathy. I don't know that I had another solution for him other than endoscopy. So I'll switch gears a little bit one more time if there's no more questions.
Yeah, we're all caught up. Thank you.
Okay, good. So 62-year-old lady who previously had an L3S1 fusion with significant back and leg pain. You can see here, This is something that, as spine surgeons, we deal with a lot. She has an adjacent segment disease here. And, when I was training, this would be kind of the bane of my existence, right? Because you don't know where the defects are. You're going to have to go through all that scar, and it's going to be a difficult case. I think this is where the prone lateral approach really shines through, where you're able to put a big cage there for indirect decompression. What we've been doing actually is, I can show it here. We're using this instrument tracking again. It's very important, as everybody who are lateral surgeons, to be orthogonal. And so what we've done is we've made a way to have the software tell you when you're orthogonal. And again, with people that have trainees and so on, I can now see, where they're going both in the lateral and AP at the same time. And so that makes it a little bit easier for me to teach, and also safer for the patient. So you can see here, when we're orthogonal, it kind of lights up. And so that we know that we're orthogonal. Now, the big advantage of this system is that if we're doing multi-levels, just if I put a big cage, it's not going to change things, because I'm just going to take new x-rays to kind of recharge that system. So you can see here, as we're putting our cob through, I can see exactly where they're going, both in AP and lateral. Another big advantage is that it really doesn't matter, AP and lateral, once you know these dimensions. So then you can rotate the bed for better ergonomics. So makes things easier also for you as a surgeon. So I think I put she went for a one level prone lateral. We extended her fusion to L2. We lost almost no blood. Now we've gotten, so good at this that, my last case that I did a prone lateral extension for fusion, that patient went home the next day. And so, taking a case that previously the patients would be in the hospital for 3, 4, 5 days, and now we're kind of almost making it an outpatient procedure. So with that, I'm going to start to conclude. I think that enabling technologies are exciting. I think it's exciting as a surgeon, it's exciting as a patient, that we're able to provide them newer ways to do surgery, and safer ways and more efficient ways. You can see, we're offering, surgeries for people that previously were not surgical candidates. I think that, we have to not lose sight of the ultimate goals of surgery. Minimally invasive surgery should not be minimally effective surgery. I think it is important to study the effectiveness and the safety of these techniques. And then I have too many acknowledgements of people that have trained me and have been really mentors for me. And it's always great to see a new generation of people that are also interested in spine. And with that, I'll conclude, if that's okay.
Yeah, that's wonderful. Thank you so much, Mohammed, for going through some of those cases. Can you talk a little bit about the software that you're using? I noticed that you don't have really an intraoperative CT, and it doesn't look like a no-arm. Is that just like a Zeem ISO-C type of machine, or is this just a floor machine that's enabled with the special software?
Yes, it's just a basic fluoro machine that that has the fiducials on the C arms, just a basic C arm, and then there's software that's running behind that. So it's actually it has no capital cost to you. They'll charge you for the disposables, but that's about it. And it's
that really got my attention. I mean, because that is so much more cost effective than some of the other toys that we're using, these days. So that, that the capacity that you just showed, and the different really versatility of what you could do with just that C arm, that was pretty exciting. And what is the software? What
the company is called TrackX.
TrackX, okay.
Yeah. It was actually the co-founder is a previous surgeon here at Duke, and I've been working with them closely to kind of make things safer and better for us spine surgeons.
Wonderful.
Hey, Mohammed, this is Mike. That was absolutely
If there are any,
Dave. I have
Mike,
yeah. Hey, this is Mike Galgano, Mohammed. Quick question for you. How did you go about pitching this idea of awake spinal fusion to your anesthesiology team? This is obviously something that most spine surgeons, ortho and neuro, are not doing across the country. So maybe you could give us a few tips and pearls how to start that conversation with them, because this is probably a pretty foreign concept to the majority of them.
Yeah, so I think it's really important as a surgeon. You have to understand, like the anesthesiologist, they're not going to agree to do awake surgery if you're going to lose 500 cc's on a TLIF. They're just not. They're not going to want to do an awake TLIF if it takes you 5.5 hours, right? So actually what I did is the first 2 years I was here, I just did a sleep percutaneous TLIFs, and we published our paper actually, if you look in IJSS, where we showed that for a 1-level TLIF, the operating time was 132 minutes plus or minus 10. So there's no variation. The blood loss was 36 cc's plus or minus 5. So when you come to the anesthesiologist and say, now I have a track record, of 50 cases where you've never had to transfuse a patient, it's never been taken more than 3 hours, there's never any, problems, then they may engage you, right? But if you don't do that, right, then you can't engage it. So that's been a real goal of mine, is to make these surgeries reproducible so that, almost anybody can do them. And that, with that in your pocket, then you can talk to the anesthesiologist of, hey, this patient may have, some comorbidities that won't allow him to be a good general anesthesia. He may be, 80 years old or 87 years old, and then they can engage you. But it's only, I think the onus is actually on you as a surgeon to prove that you can do these surgeries effectively, safely, and with no variation. Then you can start the conversation.
thank you. Thanks, Mohammed, for that. Yeah, that's a great point. I mean, I think we all know this, the anesthesiologists just have to trust you, and you have to basically earn that trust. And certainly sometimes it takes several months to a few years to get that trust, like you said. A couple of questions, one from Dr. Mamagani, of course, one of our panelists, who's an orthopedic spine surgeon from Switzerland. He said, can you again highlight the advantages of 2D nav instead of 3D?
So I think that, 2D nav has definitely advantages, and 3D nav has advantages. For me, the ability to, in this situation where, if I'm doing multiple levels of lateral, the fact that the system kind of recharges itself all the time is really, really helpful. I do, I have used 3D nav in laterals, and I actually think it's a really good technology. It's just that, again, how fast can we get these registration shots and so on. And this situation, I don't need to take any registration shots. I'm just operating. And so I think that you always have to think about, the advantages of each. So, I use the robot, which is basically a 3D nav for certain cases, like for the spinal pelvic fixation. I simply don't think that, I could do that surgery. And we have a case series coming up now with unstable sacral fractures, where, our orthopedic colleagues have put, all these different things, pelvic X fixes, have put, transiliac, transsacral screws, and I'm trying to put in, my iliac bolts, right? I don't, there's no way I could do that with 2D nav. That's a 3D nav case with a robot, actually. So you have to learn what are the, abilities and limitations of each technology.
Great. Thanks, Mohammed. And then another question from Dr. Burchak regarding the degen scoliosis. He's asking if you use the transcambin approach to insert the cages to correct degen scoliosis in older patients, or using it mostly for for focal degen cases, or do you think that approach also allows some degenerative scoliosis correction?
You know, I take every case and every patient, you know, individually. I do not think that the, you know, transcambent approach, if, you know, if there's a lot of, you know, pelvic lumbar lordosis mismatch, I don't think that this is a good, you know, a good surgery for it. So I do my fair share of ALIFs and laterals, and you know, even sometimes if I have to, you know, pedicle subtraction osteotomies to get the patients, especially the ones that are not so old, to the correct alignment. So I don't I don't usually use it for scoliosis surgery. I do it for more degen cases.
Got it. Great. Thanks so much. One, perhaps just I'll throw this out there. Let's see, Michael or Jonathan. Any of the other faculty have any questions before we wrap things up? All right. Wonderful. Well, Mohammed, thank you so much. We've already taken a lot of your time, and it's getting late on the East Coast. So thank you very much for this presentation. Absolutely excellent cases, very versatile, very diverse, and we're so glad that there are folks like you who are pioneering some of this stuff, so we can all benefit from it. Thanks for joining us today. And
thank you so much.
Yeah, of course, our pleasure. You're always welcome. And for all the other colleagues, of course, as you know, this will be on YouTube later, and we will distribute the link. And Dr. Jonathan Rassouli will be hosting next week. And imminently, we will, of course, also advertise what the topic will be, who the guests will be for next week. So thanks, everyone, for joining us. Have a wonderful night. And Mohammed, thanks again.
Thank you so much. Yeah, have a good, wonderful day.
Take care.
Bye.